Some heroes and heroines wear masks or caps, but these ones wear white coats. They are the health professionals taking care of HIV-positive and tuberculosis patients in the Kavango East and West, Omsati, Ohangwena, and Oshikoto regions. They are ordinary women and men doing jobs many people take for granted. The jobs of helping others gain their health back or managing long-term illnesses. For the majority of people, getting to a doctor is as easy as making an appointment and driving there. But what if you live in a rural area where the luxury of a car is not at hand? Some have to either borrow money for transport to get to a clinic or walk for hours to collect their medication. This challenge was observed by various healthcare providers like the Health Ministry, but a solution was found after consultations with various institutions like PEPFAR, USAID, CDC, and IntraHealth International. They decided if patients cannot get to the clinic will go to the patients. Once a month, Sister Rusa Shipena and her team travel for over 3 hours from the Onanjokwe District Hospital in the Oshikoto region to the remote village of OHAIMBADA, northeast of the hospital. About 1 hour of the 130-kilometer journey is spent traversing thick loose sand, forests, and to get there needs a skilled off-road driver because there are no road signals at all.
There was an outcry from the community itself saying that they are traveling long distances to come to these outreach points, and also the problem with them. They also wanted other services like these HIV services. And that's why we were having a problem in trying to explain to them that we are in problem because we are understaffed and we don't have even the equipment or even the transport so that we can carry out. We have started slowly taking the services to the community. And in between 2015 and 2016, with the assistance from the private partners, IntraHealth, in collaboration with the Ministry of Health and Social Services, we have get some assistance from this partner. We have received some trainings from them. Our staff were trained on HIV-related issues, and from this partner, some of the staff members were recruited, and this have made it possible for us so that we can take the outreach services to the community. Because we have received some staff, we have received some equipment from them, we have received cars, and also drivers who are taking us to the outreach points. In taking of medication with our clients here at the outreach point, we are really feel relieved that in the past we used to see clients at the center at Chanamtango, Onanjokwe. Clients are not really adhering to take their medication. They are having problem in taking their medication. But what we have identified with the outreach point here, people are supporting each other here in the community. They are willing to take their medication, and they are coming for their follow-up. They are not most of them. They are not really missing their follow-up as they used to do at the main center, which is Onanjokwe. Here, people are really motivated to take their medication and also to come for follow-up.
Sister Shipena and her team do not leave OHAIMBADA before attending to all clients, about 100 of them, a task that takes up the whole day. They hardly take breaks, and the next day they do it all over again when they travel to the next village to take care of the sick.
We are very grateful for the government and IntraHealth for joining hands and coming to search for us in this deep forest where we have suffered for a very long time. Now, when our children fall ill, they can just come here and no longer have to walk the long distance to Onkumbula.
Nurse trainers are needed to ensure these health practitioners are ready to ensure the right medical treatment for HIV is administered and TB testing is carried out.
As you know that training is not enough. We have seen over years, and I think evidence has come out that when people have done training, it's a theoretical knowledge. It needs to be coupled with a hand-on experience. So this is what we call the mentorship program. That mentorship bridges the gap between training and hand-on experience. So we have the mentors on the ground, we have the doctors' mentors who are the regional mentors, who team up with the nurses who are the district mentors to make sure that they bridge the gap between the theoretical knowledge, which they learn from the training, from the classes, and the hand-on experience when they are seeing a patient. So the mentors, they do one-to-one mentorship where they sit with the clinical nurses after the training to make sure that the knowledge they gain in the training, it is transferred to the practical experience on when they're managing the patient.
Thomas Lazarus is a nurse trainer. He received his training from IntraHealth and now has the daily task of equipping field staff with the necessary knowledge of how to take care of others.
First of all, I like to say that I found out that although we are, as nurse mentor, you are expected to have above knowledge. You learn a lot from others. You find these old nurses, they will even learn from this process. Maybe you don't, like when we started, you know, we, like young ones, when we started, we like young ones, you know, we like fast things, quick. But you learn to be patient. You learn how to build relationship. You find different people. Some have resistance to change. You need to be on their level in order you need actually to be adaptable to their situations, to assist them there and there, even to strike a joke, just to you know, that you find some tense and so on. And then there's one thing, this is a coaching, it's a guiding, it's not a teaching, because you find that you don't like to be seen like you are a teacher. You like to be like you are guiding someone, and that it works. Patients now are receiving their ARV medicine at the nearest health facility. Now they have a choice, options, either to come here or to be the nearest facility, unlike in the past. And the patient, the adherence has improved because they have even those who do not have money, they can just walk to the nearest health facility. What I have seen as a good impact is that all those patients who were started at the clinics, I only, out of hundreds, I only observed 2 who have poor adherence out of hundreds. Because why? Because they are at the nearest health facility and the nurses monitor them better than when we have 1,000 here. You lose your focus. To the nurses, their knowledge has improved, increased. Unlike in the past, when they were thinking about initiating someone on ARV, it was a big thing. But now they are enjoying it. And then I like to tell them, like, to strike a joke like that, it's not a routine, because they only have a routine, immunization, weighing, immunization. Now they have added ARV. No, HIV have a lot of things. There's this one, testing, monitoring, initiating, and so on. It's another positive things on their working. And then one thing I like to say, when I started here, I found one experienced nurse, also I mentor her, and then a young one. Both of them, they got the promotional jobs to work for HIV. I'm higher tenure. I'm also losing my nurses because we mentor them. When they go for interview, yeah, which is also is a positive thing.
The training is provided by international donors such as IntraHealth International in collaboration with the Ministry of Health and Social Services, with financial support from USAID through PEPFAR. It helps to ensure clients in remote villages get their medication on time.
We had doctors mainly providing these services to patients, meaning all patients practically come to the district hospital for treatment. But then, after some time, we noticed that the centers where these programs are being provided are always jam-packed. People are not able to even come. At times they don't have money. Our patients can't come because they do not have money. And then government thought of using nurses to provide this service to the community, to members of the community. And also, there was also the thought that, look, instead of having it at the hospital only, health centers and clinics should also be able to provide these services. And that is where NIMAT came in. And nurses at clinics and health centers have to be trained. Even some at district hospitals were also trained to be able to provide services for our members of community that are affected by the virus.
This outreach service is indeed of benefit to the residents in remote villages who do not always have the financial means to pay for transport to the nearest clinic, hospital, or any other healthcare center.
So we are glad that when Interest International came, you know, Interest International is an organization which works with the Onanjoko district, Onanjoko and Omthia district, and they get funding from USAID. So when they came in somewhere in February 2015, and I think we started getting a lot of attention from them somewhere around April 2015, they reached the councillor and the clinic, and they were looking at how can they establish full-time services for Omtere clinic. So one of the ideas which came up was to increase the space. How can they make a space, more space to the clinic? And the quick idea which came up was, can we put in a quick measure, can they buy like a prefabricated building which can be used to increase the space? And that was the best idea. The other idea which came out was, how can they increase the number of the nurses in the facility? So they decided to learn ADVET in 2015. Then they were working at the NAMPA to increase the number of the staff. And luckily, I think somewhere around the February last year, they got some extra funding for acceleration plan, which gave them more power of hiring more nurses for some of the identified clinic which had critical shortage of the nurses. And Omtere was one of the clinic. So Omtere was blessed to have at least 2 posts for the nurses, and we were glad that one of the nurses who come from this local community, who was working on Njokwe, volunteered himself to come take over the services to Omtere patient. So in September, from September last year, 2016, we approached the councillor that can we use one of the offices which were not occupied to run the services. And we are very glad that the councillor and the team, they offered the office, and all the patients started getting services from Monday to Friday instead of relying on the outreach team when these new nurses came on board. So they were seeing patients in the councillor's office, and that time the Interest International with the USAID, they were working together to make sure that they procure the prefabs so they can increase the space for the patient.
Technology also plays a big role in ensuring not much time is wasted in the healing process. More than 230 SMS printers installed all over Namibia provide health practitioners with the results of clients' blood tests in the shortest time, so clients can start with the treatment as soon as possible in efforts towards a prolonged life. The SMS printers are installed at selected clinics and deliver HIV, TB, or any other blood tests within a time frame of 3 days. Nurse in charge at the Mashare Clinic in the Kavango East region, Alphonse Dikua, said the printer contributes to the doctor giving the patient their test results as soon as possible, so such patient can start treatment sooner if such patient so agrees.
What are the reasons for such an SMS service, and how do this community benefit from this service?
So the community really benefits because we intervene with the client sooner as we get the result. Because unlike in the past where the client have to go and wait at home for a long time, and then sometimes you find that the result get lost on the way from NIP to the clinic. But in our days, since we got the printer here, so the result will never get lost. And then the client will start soon on treatment. For example, like if you take a sputum, and then if the sputum becomes positive, then immediately the client will start on TB treatment. That also helps to reduce the spread of TB in the community.
Infrastructure is limited, communication is limited, yet there's a success story here.
Yes, that's why you are here. So, because we draw up SOP that we are using, that all the children, exposed babies that are born at our hospital, they are recorded and tracked. So from the time they are discharged from the maternity ward, they go through adherence counseling on prophylaxis that the children should get, cotrimoxazole, talk of nevirapine. So they breastfeeding, exclusive breastfeeding. So they, before they go back to their places, they have to go under counseling before on discharge. And at the same time, they have to tell us where they're going to be followed up, where are they going to go, which clinics is the nearest where they are going to go for immunization. So it's from there that we refer. If, depending on the clinic they have chosen, we refer. There is a biodirectional form that we give to them, and we document in our district register for all exposed babies.
I would say it's not really us in maternity. I think it's the teamwork that has helped us as a district, because when you look at what our colleagues are doing on the other side, that's the CDC clinic, they are trying by all means to ensure that they spread the news that every pregnant woman is tested for HIV before she comes for delivery. So at least as we receive these mothers, we have the results with them in the passport, which helps us even as people in maternity to know at least how to take care of this mother and their baby. And we've been working really as a team where we find even cases of mothers who are not tested or who are not on treatment. At least we liaise with the CDC. They are started on treatment. And not only that, we have also made it a must that this treatment is kept in the department, so that peradventure, if the woman comes at night or over the weekend, we don't wait for that mother to say, come Monday, that's when we initiate treatment. No, we start the treatment from here.
However, all these luxuries and benefits of funding, vehicles, and infrastructure do not mean anything without the heroes and heroines in white coats, ensuring clients receive counseling, testing, and medication. They also try to convince patients to regularly go for follow-up visits to their nearest health centers. The beneficiaries in relatively good health are testimony to this cooperation between the Health Ministry, PEPFAR, USAID, CDC, and IntraHealth International. This outreach service is indeed of benefit to the residents in remote villages who do not always have the financial means to pay for transport to the nearest clinic, hospital, or any other healthcare center.
Ashi anempano pu kwa chamuno kucha otayivurika simbo jadari kakala jasika joku kataro miti shimarwa kashipo. O shakara tashitu thimini kenai atufuto mirongo heari ruampono kuzampano kuya kokankoro kukataro miti. Simbone sukujoma sukutaka kasika moja tokanashi.
No, atufika mashikane fimbole tunde nandonga watutsa kudukangoji bashasho tujite kucha tatuduru nande obapangi betu boya pandeka tuposha ashi watpetero makulo shilonga tutwitikule bali mefikula shikula komo
nako matonelo twete kucha nako hakungone washipangelo shoven twete kucha takurwa hashi ngashi kwa matuniro hapo kwa humbole iko na kwa mana na kwa shikunde na kwa kangola kwa ben
nonda indudite ohokuyonene ni omitidata meke okuyanjwa no salisa kumika omwenye wange opondi dule kuleleteka ongala mwenye yange nokujamo atukala hatutambula na omiti detu na bakwetu nonda dinine okunwa omiti dange fio opomandilindi na ukolele.
Like previously, we were not starting patients on ART. It was the work of the doctor only. So for now, we are well equipped as nurses to manage patients on our own.
I underwent the training in 2014, around November, if I'm not mistaken. And I've benefited a lot from the training because I was taught like how to initiate patients on ART and also how to monitor and many other important aspects in relation to ART. It helped me to provide better services for the patient because now I've got a better understanding about the ART, and I know the correct regimen to start the patient and in relation to the patient's condition, and to also interpret the laboratory results and to take the appropriate action and to refer accordingly.
Firstly, some patients have got things to say, but they don't know where to say it. So a patient will just, when the patient enters, the manner you receive your patient, first impressions are the best. So when she comes in there, she sees a smile and you talk to her. Oh, how are you today? Can I help you? What happened? Why didn't you come yesterday? Rather than shouting at him, then she will open up. My message to the youngsters, this is not like cancer, okay? The cancer can be detected after a long time, and we accept it. HIV is something that is detected even from delivery. So it doesn't mean if your grandmother or your grandfather has got it, you must undermine him. Hey, there are certain circumstances that lead to these things. Our respect for the elderly should remain. Number two, we should appreciate the help that we've been given by these UNICEF, IntraHealth, all these companies, or what can I say, these projects that are helping us. And we must try and cooperate with the treatment.
So with IntraHealth, we were trained, empowered to prescribe ARV medicines, to look at the patient's conditions, and to assess the progress. And our aim is to identify those who are infected and to put them on treatment. And once they are on treatment, ARV treatment, their viral load is suppressed. So we are aiming also on viral suppression.
The program aims to reach the 1990 goal of UNAIDS and the Health Ministry. The goal is that by 2020, 90% of people living with HIV will know their HIV status. 90% of those diagnosed with HIV infection will receive sustained antiretroviral therapy, while 90% of those receiving antiretroviral therapy will have viral suppression.